أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم أشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبده ورسوله. I wish to convey my sincere Jazakallah to all the program committee for giving me this opportunity. So my talk today is about the clinical spectrum of atypical dementia syndromes. Did it go forward? Yes. And in full disclosure, I will not be touching on the subject of how to prevent dementia. So in some ways, it doesn't tie into the previous talk. So even though dementia is not named in the Quran as a disease as such, but these verses really highlight the cognitive and the functional decline that happens with old age. So the first verse is from Surah Al-Nahl, the bee. And Allah creates you, then He causes you to die, and then there are some among you who are driven to the worst part of life, with the result that they know nothing after having had knowledge. Surely Allah is all-knowing, powerful. And then the next verse is from Surah Al-Rum, or the Romans, or the Byzantines. And the verse says, "It is Allah who created you in a state of weakness, and after weakness gave strength, and then after strength caused weakness and old age. He creates what He pleases. He is the all-knowing, the all-powerful." So my objectives are to just broadly define dementia and its subtypes, talk a little bit about the prevalence of these subtypes, and give a very, very broad overview of the clinical presentation. I will not discuss neuroimaging, biomarkers, and treatment options in the interest of time. Sorry, did I skip a slide? Wait. Yes. So, thank you. Before we actually touch the content, I included a slide about language. And I think language really matters when we talk about older adults. So I wanted to create the space to discuss that. Avoid saying elderly or seniors. The correct terminology is actually older adults. And in order to give dignity to both our patients and their care partners, it's better to use a person living with dementia rather than, "Oh, my patient is demented or senile." A lot of our nursing affiliates may use the terminology, "Oh, they are a total feed," or "they are a Hoyer lift." So it's much better to define them by how much help they need. For example, they need help with eating, or they need a Hoyer lift to get out of bed. We sometimes talk about patients with dementia with behaviors. It's better to call it symptoms of distress or unmet needs. And then it's always better to call the caretaker as the care partner, because I think the caretaker is definitely a word that does not include some of the things that the care partner is doing. So broadly, dementia is a collection of symptoms, cognitive, functional, and behavioral, that are often caused by a specific disease. So it's an umbrella term. And most of us, if we, let's say, pull 10 people that are over 90 off the street or off a cohort, the most likely dementia that they are going to have, if they have a cognitive decline, is Alzheimer's. So you'll be statistically correct if you make that diagnosis in 60 to 70% of our patients. So again, I'll reiterate that it's an umbrella term. And the biggest subtype is Alzheimer's, but today we'll be talking about some of the other subtypes, which are vascular, Lewy body, frontotemporal, mixed, and then there is a small, tiny amount of what's called rapidly progressive dementing illnesses. Okay, I seem to have gone. All right. So the first subtype I'd like to talk about is Lewy body dementia. Some people put it under the umbrella of dementia of Lewy body type. And there's an emerging body of evidence that now basically divides dementia into tau proteinopathy and alpha-synucleinopathy. And even for those of us who are not that interested in how these pathologies happen in the brain, suffice it to say that the synucleinopathies are a bunch of neurodegenerative disorders which are caused by the accumulation of a certain protein called alpha-synuclein in both neuronal and non-neuronal cells. So these are some of the core clinical features of Lewy body dementia, and on the other side of the slide are the supportive clinical features. The core clinical features, and I think this may be important for even some of us who may be care partners or may be experiencing a loved one in our families that have dementia, I think it's important to be cognizant of these core features. So the first is cognition tends to fluctuate along with the level of alertness and attention, almost on a daily basis. Patients with Lewy body dementia often have recurrent, pervasive, detailed, and very vivid visual hallucinations. They often have a REM sleep behavior disorder, which may actually precede the cognitive decline by years. So it's important to sometimes interview the spouse or the partner about REM sleep disorders like vivid dreams, calling or crying or yelling in their sleep. And then lastly, patients with Lewy body dementia often have motor symptoms of Parkinson's, which are an asymmetrical tremor, rigidity, and bradykinesis, which is defined as a very almost a slowness in initiating movements. Some of the supportive clinical features are exquisite sensitivity to antipsychotics. So our pharmacy community will recognize that these patients, if you give them an antipsychotic, they are going to react by becoming extremely rigid, far more altered, and you could actually increase their hospital stay by days. And Lewy body dementia often manifests with severe autonomic dysfunction. So patients can experience falls, drops in their blood pressure, excessive sleep, loss of smell, systemized delusions, apathy, anxiety, and depression. And there is good data to indicate that anxiety and depression can precede Lewy body and often the alpha-synucleinopathies by decades. So I forgot to mention that Lewy body dementia is the third most common of dementia. So approximately 10 to 12% of all patients diagnosed with dementia will have Lewy body. Next is vascular dementia, or for those who trained very early on or who are more seasoned geriatricians or neurologists are used to seeing multi-infarct dementia in place of vascular dementia. So vascular dementia also has 4 phenotypes. One is the subcortical ischemic vascular dementia, which basically exhibits just by a slow processing speed, slow speech, slow executive abilities, overall just slowing in every domain. Then we have the most commonly known post-stroke dementia, where someone actually has a stroke and develops a cognitive decline either immediately or within 6 months. And obviously, this happens when the stroke happens to include the angular gyrus, thalamus, basal forebrain, basal ganglia, or posterior cerebral artery. The third phenotype is multi-infarct dementia, where you have multiple large cortical infarcts. And because you actually have a large infarct that can easily be seen on an MRI, you usually have motor signs as well. So you would have apraxia, which is difficulty doing motor movements, aphasia, which is loss of language, visual field deficits, or symptoms of either paralysis or neglect. And then the last kind is mixed dementia, which has pathologies of both Alzheimer's and vascular dementia. And this is not surprising because age is the hardest risk factor for Alzheimer's. And as we all know, with age comes hypertension, diabetes, and a risk of strokes. So mixed dementia is actually quite common. The third atypical dementia is frontotemporal lobe dementia. The big thing about this dementia versus the others that I've talked about is this is a disease of younger people. So this often happens in people under 60. It often masquerades as a psychiatric illness, so a lot of these patients will end up seeing the psychiatrists or their primary care physician first because of changes in their personality and behaviors. Head trauma and thyroid disease have been linked with the development of FTD, and there is a particular protein degeneration that happens with frontotemporal dementia, including TDP43. So there are 3 variants of frontal lobe dementia. One is the behavioral variant, where patients present with altered behavior, personality changes, disinhibition, loss of emotional reactivity, and something I find super helpful is apathy. They become, very unmotivated to do the things that they normally would do. They have impaired abstract thinking, and their executive function worsens over time. The second variant is the semantic variant, where you have quite a significant difficulty with word finding or understanding the meaning of words, impaired comprehension, and extreme amount of difficulty in recognizing unfamiliar objects or face. And then the last kind is, some of our neurologists may be familiar with this, is the primary progressive aphasia. These patients present with halted speech and just jumbled words, and they don't make a lot of sense when they talk. They have difficulty in understanding complex sentences and naming objects. So the 2 key features in frontal lobe dementia is that their speech is affected. Either it's fluent and nonsensical, or it's halting and still nonsensical. And then there are a lot of personality changes. And then there's this small cluster of rapidly progressive dementing illnesses like Creutzfeldt-Jakob disease, which is a prion disease caused by a tiny particle that is even smaller than a virus. Vasculitis, which is basically inflammation of the blood vessels. Progressive multifocal leukoencephalopathy. Wernicke's, which is associated with high alcohol consumption and thiamine depletion. And then there are some unusual variants like mitochondrial disease. So here are some take-home points. I know some of you may not be entertaining careers in neurology or geriatrics, but I think it's hopefully useful to know for everyone who cares for older adults. 80% of all dementia is Alzheimer's in type. Vascular is the second most common. Lewy body or DLB is the third most common, highlighted by visual hallucinations. There are a handful of Lewy body dementia associations across the nation. Reversible causes are less than 10%, such as vitamin depletion, thyroid disease, etc. Rapidly progressive dementing illnesses are rare, and if you happen to find a patient who is literally declining in a matter of weeks and months, then look for referral centers, and the best ones around us are Penn, UCSF, and Mayo. So I'll end my talk here, and hopefully we'll have questions at the end. Jazakallah.
Jazakallah, Dr. Ahmad. And with that, we go to on the men's side to Dr. Atar Malik. Please, Dr. Atar Malik, go ahead, and then we'll take the questions at the end. Jazakallah.